Dear colleagues, it is my pleasure to be able to stand in front of you and to present the progress we have done in the last 9 months in the framework of the Translational Medicine program and the Translational Medicine Center. I'm Péter Vámosi, working in the Heart and Vascular Centre of the university, and according to my mission, I wanted to achieve as much progress in this research as possible in the last 9 months. My projects are all covering the topics of improving the outcomes of cardiac electrophysiology procedures. The first group of them, they are covering complications of invasive electrophysiology procedures, and we want to compare ultrasound guidance with the traditional approach and its effect on complications. And my second, or I could also say third project, it was the development of a machine learning-based prediction system for 1-year all-cause mortality of patients undergoing ventricular tachycardia ablation. All 3 have started in the last year, and currently one of them, the randomized controlled trial on the first topic, it's so to say on hold. We are making progress with the other 2, and as soon as we are finished with the article writing of those 2, we have submitted them, then we will come back to the randomized trial I have mentioned you. So as for the very first project we have started in the Translational Medicine Center, as I said, it covers comparison of ultrasound guidance during EP procedures with traditional guidance during the venous puncture, and we are conducting a systematic review and a meta-analysis. We have made some progress, but we have to wait for the final data analysis. As soon as we have it, then it will be implemented into the draft version of the paper I'm preparing right now, and this month we want to submit it to the Frontiers in Cardiovascular Medicine, which you might be familiar with as it was already mentioned today. It's a journal with an impact factor of 6. A few sentences about the background. Cardiac electrophysiology procedures need in every case a vascular access, and most of the complications of the procedure are related to this. They have a negative impact on the quality of life of the patient, and by prolonging the hospitalization time, they are also incurring extra costs for the healthcare systems. You can use ultrasound to clarify the vascular anatomy, and it is widely known from other subspecialties of medicine that it has significant benefits on the outcomes. It is included in nephrology guidelines. It is, of course, included in intensive care guidelines, but not yet in the field of cardiology. We wanted to investigate if in our field it also has the similar benefits. That means if it reduces major vascular complications during these procedures. That's why we assess adult patients undergoing electrophysiology procedures, and we compare our intervention, the US guidance, which helps to clarify the anatomical situation of both the femoral artery as well as the femoral vein. And we compare this with the traditional approach. Of course, with palpation, you can only palpate the femoral artery, and you have to know that in most of the patients it's located, the vein is located medially to the artery. So the vein itself, of course, you cannot even palpate at all you can just rely on this, what I mentioned. The outcomes, as primary outcome, what we assess are major vascular complications as defined in the expert consensus document of the arrhythmology societies of the five continents. And if our hypothesis is sustained, then of course it will have a huge clinical implication that we knew already in advance, because then we have a cost-effective way to decrease complication of these patients. We have conducted a systematic search in last November and found over 13,000 articles. We, in the end, could include 12 full texts, and we already have some primary outcome data. These will be adjusted by the statistician, I hope, until the start of next week or middle next week. Then we can finalize the numbers in the paper, but of course they won't change much from the numbers we have right now. In the preliminary statistical analysis, we have found a 60% reduction in major vascular complications, so there is a huge reduction in odds ratio based on altogether 12,000 patients. We have, as secondary outcome, also assessed the effect of ultrasound guidance on the number of total vascular complications, and we could demonstrate an even bigger benefit on this outcome. There is a reduction of the odds ratio of more than 70%. So these two figures were already able to demonstrate that there is clear evidence for a significant benefit of adding this extra procedure or this extra way of doing this part of the procedure to the EP lab, because it reduces the incidence of major vascular complications and of all vascular complications as well. Of course, because there is only one RCT, there are the known limitations known to observational studies. According to this, the use of ultrasound is encouraged in daily practice, and we want to also conduct a randomized controlled trial on the same subject, which will provide even stronger evidence. As conclusion, we can summarize that ultrasound-guided venous puncture causes less major vascular complications, so it is advisable to use this in the daily practice. So as for my second project, it was a registry, it was a development of the prediction system I already mentioned to you. That means the predicting 1-year all-cause mortality of patients undergoing VT ablation, and it was based on our registry of around 300 patients. Monomorphic ventricular tachycardia is a life-threatening condition and the most common cause of sudden cardiac death. Medication is often ineffective, and ICDs provide a way to prevent sudden cardiac death, but they have a negative impact on the quality of life of the patients, and they are also associated with higher mortality. That's why catheter ablation is needed in some of the patients, and even with a successful procedure, we still have a very high, around 30% 1-year mortality. That's why, because this group of patients, they have very high burden of comorbidities in average, but there is a big heterogeneity among the patients. That's why we wanted to establish a new risk prediction system which can help us to identify patients in need for a more thorough follow-up, which can assist post-procedural decisions, for example, on the frequency of follow-up meetings. We, as I mentioned, have used our data gathered in the last 15 years of around 300 patients who have fulfilled the inclusion criteria. There you can see an image of this registry. We have included data of around 70 procedural parameters, which we have used as input for training different machine learning algorithms, and we have compared these algorithms with each other according to the area under the ROC curve, and that's how we have chosen the best performing one. And we have also assessed with calculating Shapley values which of the included parameters has the most influence for the prediction result. Here you can see with green the ROC curve of our best performing model. This has significantly outperformed previously used score systems such as the IVT scores and the pain ESD score. We have, as I mentioned, calculated the so-called Shapley values, which refer to the strength of impact on the outcomes. And that's how we could see that the mitral E-wave deceleration time had the most influence, followed by presence of a cardiac resynchronization therapy device, followed by age, and among the first 5 there was also hemoglobin concentration and presence of electrical storm or multiple ICD therapies. We have also found some unique predictors which were not included in the other 2 score systems I have mentioned. For example, creatinine concentration and if the ventricular tachycardia was incessant or not was only included in our study as a positive predictor or a significant predictor of the outcome. As a conclusion, I can say that we have developed a new and a more efficient algorithm to predict the 1-year mortality of the patients of this very prone group. And as a future plan, we want to have a web-based platform which we will use for external validation data gathering. And of course, after finishing the first paper, we will start writing the publication on these data. Thank you. This is summarized also on this slide, and thank you for your attention.
One question. Did you make a sub-analysis on different anticoagulation strategies in the patients?
In the first study, you mean? There is no,
yes.
There is no exact data actually on this because the papers are only reporting the ratio of patients who were in each paper who were anticoagulated or were not. But of course, we don't have specific data on the subgroups in each of the papers. So that's why we can only perform a subgroup analysis on AFib ablations, atrial fibrillation ablations, but not on anticoagulation itself, actually.
Right, because it could have a great effect on this.
Concerning the second study of yours, with the machine learning, if I'm right, just tell me, hemodynamic instability is a neutral factor during VT ablation concerning the mortality rate. How may it happen? The last one, below.
Yeah, actually there was not a high rate on reporting this. And of course we were also surprised by this outcome because you could think that those patients who have already developed HD instability during the procedure itself, they would more prone for mortality itself. And it was kind of a surprising result for us as well. How to explain it? I think it had to do with the patients having HD instability during the procedure, having the procedure stopped earlier as well. But as there was not a big number of these patients, that's why maybe this model didn't find a significant connection between these two.
Yeah, thank you. It would be worth to just check them over, all these patients with the clinical situations, because this may be influenced by the catecholamines that we use or the mechanical ventilation during the procedure and so on. So maybe they needed some kind of intensive care that had the stabilization process, and it may influence the outcome as well.